So case study 1, this is Mary. We are going to thread Mary and case study 2, Jerry, throughout this presentation. So we'll keep coming back to this and revisit it. So some of the information has been changed just to protect people's identity, but we've kind of combined different pieces of multiple different cases that we have seen over the years. So Mary had a total hip arthroplasty after her husband shoved her down the stairs. After surgery, she went to a long-term care facility for therapies and safety. She recovered to independence in all ADLs and required minimal assistance for some instrumental activities of daily living, like home maintenance, cooking, more complex meals, etc. During the discharge planning, the OT and the PT recommended a home evaluation, as did social work and nursing. Mary's daughter offered her home to Mary to return to rather than to her husband's apartment. No one discussed the abuse, but the team, family, and Mary knew about the danger if she were to return home to the apartment. Dr. Simmons, do you want to review this case study? And then we'll do a poll question.
Sure. So case study 2, Jerry was admitted to a long-term care facility from the hospital after developing a stage 4 pressure ulcer with several severe tunneling and total destruction of the skin and the gluteal muscles. Jerry had a stroke 3 years earlier and had very limited mobility. Family was caring for her at home. She stayed in the recliner at all times. She did not report any pain from the pressure ulcer. Family members all worked full-time in the non-healthcare fields. There were families that took care of her and took turns staying with Jerry. They expressed grave concerns about the pressure ulcer and having to place Jerry into a long-term care facility. So just a couple questions, and you can put this in the chat. What is the reason, do you think, that she did not have any pain? Anybody have any thoughts? You want to, here we go. No feelings, no numbness from the stroke, no feelings from the stroke? Certainly, yes. And we don't have an age for her, but we do know that with elderly, there is that they don't maybe always have as much feeling, and so they tend to have more pressure ulcers from laying, they just have those nerve endings that are not there. So, and how do we know if this was abuse, neglect, or lack of caregiver training? And I think that's something that it's a question of, boy, we don't know yet. We have to do some, take some history, do some assessments, find out, what the caregivers know about turning, repositioning, what their knowledge base is. Excellent. Good. Yep. So hopefully as we go through the presentation here, we'll circle back to some of these case studies like Dr. Jansen was saying. So
thank you, Dr. Simmons. So yeah, it's a little early to know that, and that's why we're doing this session. So how many of you have seen this? How many times in the last year or so have you seen similar case scenarios that made you think the person has a serious safety risk at home for elder abuse? And it's a survey, but there's a poll question that Dungeon can make available. How many times in the past year have you seen a similar case scenario that made you think this person has a serious risk of elder abuse? Thank you. So 1 to 5 times, 67% have seen this 1 to 5 times, hence the reason for participation here. 6 to 10 times, and quite a few of us luckily have seen it 0 times. Thank you. Okay. So this is the focus, the objectives for this is we want to be able to screen. We couldn't answer the question for case study 2 on Jerry. So we want to be able to screen for the risks and signs of abuse or neglect. And we want to use interprofessional collaboration to create interventions for safety and proper care. So now I'm going to turn it back over to you, Dr. Simmons, to describe some of the elder abuse facts and information.
Certainly, thank you. So elder abuse is a silent problem. We find that it robs elders of their dignity, their security. In some cases, the abuse costs them their lives. Up to 5 million older adults are abused every year. The loss from financial exploitation is estimated at $36.5 billion. So we do find that the National Council on Aging, NCOA, has been working on advancing some legislation that funds the Elder Justice Act and elder abuse protection of the older Americans. Are the prevalence of elder abuse? You know, when we're looking at the aging of America, and we all know that the baby boomers are aging, I think it's interesting that every 7 seconds, someone turns 65. So adults over 65 make up almost 15% of the population, and that is going to rise. At least 10% of older adults experience some type of abuse every year. There is a higher percentage of older adults that live in the rural communities. If they're finding that some of the elders are moving into the rural communities because of some, maybe more crime rate in the more urban areas. I don't know. Anyway, so they are finding that per 1,000 people in rural areas, there's one case reported for every 26 events, compared to one case for every 24 events in some of those urban areas. So why does this happen? Why is it that we're seeing, that there's not the abuse rate, it's not reported? So there's really no U.S. studies that are being done on elder abuse. There's very poor historical research. Only 21% or less of the cases are reported and confirmed. And we do know that the number of reports are increasing, and I think it's because we're starting to become more aware. We're asking more questions. Primary care providers are asking the question now, do you feel safe at home? And they do have the PHQ-2 and PHQ-9 that they are using as part of their assessment also. So hopefully that will catch some of these abuse situations. So many states do not have good reporting systems. Minnesota, for example, has an elder abuse reporting phone line. However, their newspapers report that there were thousands of reports behind in their investigations. And I know when I've talked with some providers, that, I've asked them, do you report your suspicions of abuse? And many of them will say, yep, they do, but might get repeat, patients that will come into the office, and they're finding that they continually report it, but nothing's been done because they're so far behind on their paperwork. So hopefully, that will change. Couple of estimates: 1 to 2 million older adults have been abused. 1 in 14 incidents reported to the authorities. And some of the providers have said they just stopped reporting it because it doesn't go anywhere. And that's very unfortunate. 1 in 25 incidents of financial abuse, and that's about 5 million per year. For every 1 case of abuse, they feel like 5 of that goes unreported. So one interesting thing is that some studies found that approximately 50% of people that have some type of dementia have been mistreated. And I think that sometimes people don't realize that even with mental illness, if you have somebody who has mental illness or who has dementia, it's very difficult to care for them. And have heard also from providers that, well, the person that has dementia is not going to remember that they got mistreated anyway, so they're not going to report it. So some of the social isolation. So what makes an older adult vulnerable to abuse? So social isolation can be a risk factor. If the older adult is living at home with the caregiver and the caregiver wishes to go out of the house but cannot because the older adult does not want to or cannot go out. Social isolation also can occur if the older adult is being abused. They don't want to take that elder out into the social setting because they might see some signs of abuse. And we talked a little bit about the cognitive impairment. with Alzheimer's or those who have a neurocognitive disorder and that underlying mental health disorders and illnesses. Underlying interpersonal violence is if there has been abuse in the past. Maybe the elder themselves abused their caregiver when that caregiver, maybe that was their caregiver as a child, and now that child is caring for that elder. And that child who's been abused by that elder might say, it's their turn now. So I was abused by them, so I think it's okay for me to abuse them. And that's certainly not correct, but that can be a problem. So some of our societal reactions is that it's just an isolated case. This doesn't really happen. So then it doesn't get reported. This is coming from sick people, not regular people. Are they making it up? And I've heard that from providers. They'll say that, they'll be talking to the elder or the family, and they'll say, no, this isn't really happening. This is not, they're just making it up. And some will say it's the older person's fault for living there, or, they shouldn't be living with him or her. They know that that person is an abuser. So another reason, though, that elders don't want to report abuse is because they're afraid that the caregiver is going to abandon them, and then they have to go into a nursing home. So I remember when I worked in psychiatry, talking to a woman who had been abused, and she said, well, she felt like she was getting attention. She said, bad attention is better than no attention. So that can be an issue also. So I'm going to turn that over to Dr. Jansen now. Thank you.
Thank you. I'm glad you emphasized that part about the older adult not wanting to report because they'll lose their caregiver. And I witnessed that several times in my practice. They just didn't say anything because then, for one case, he wouldn't be able to live with his friend anymore if he reported that his friend was abusive to him. And then he'd have to go back to the nursing home, and he just absolutely did not want to live in a nursing home. Some people would do well in a nursing home, but this gentleman did not. So we do need to talk about some of the demographics about what some of the perpetrators mean. These are just demographics. It doesn't mean that's true to every case. Every case is definitely different. But some of the statistics from the National Center on Elder Abuse indicate that half of the perpetrators may have a criminal history. A fourth have prior domestic violence cases against them. 2 in 10 had drug or alcohol record. 16% have been in prison. And then most of them were formal or informal caregivers. A formal caregiver is one who's trained and paid for the act of caregiving. An informal caregiver is a caregiver who is not typically trained or paid for caregiving. And a lot of times that's family members or friends. 57% were partners or spouses, so a little over half. And then half were actually using drugs or alcohol during a particular incident. 3 in 10 had a history of mental health illnesses. 4 in 10 were socially isolated. So that theme comes back again with the social isolation, which brings in that rural statistic. The rural areas tend to be a little bit more isolated. Perpetrators were both men and women. 60% were family members, and 2/3 were adult children or spouses of the person. So we need to differentiate a little bit more between what abuse is and what neglect is. So abuse is the willful infliction. Willful infliction is the key word for abuse. Willful infliction of injury, unreasonable confinement, intimidation, or punishment that results in physical harm or mental anguish. There are 3 types that are typically classified: physical, psychological, and material or financial. And so physical abuse typically can be any bodily injury. The psychological abuse is fear tactics, for example, or defamatory comments. And then, of course, material or financial is taking money that does not belong to them. And then there are types of neglect. There is active and passive. Active means it is conscious. where it's intentional and conscious, they know they're doing it. Passive means they're not conscious, they're not realizing that the neglect is being occurred. So for example, an active might be restraining somebody, or excuse me, neglect might be withholding, neglect would be withholding particular services, withholding medications, withholding food, and that might be active, but maybe withholding medications could be passive as well if they don't understand how they're supposed to give the medications to the person. And so they're not necessarily doing that intentionally. Any questions on that or anything you want to add in, Dr. Simmons? No, okay, thank you. So how do we evaluate this? From an interprofessional healthcare team member, most team members do not typically take over and conduct the actual full bore evaluation of abuse or neglect. That usually is left to the county social services or particular agency or the police. The physician may be involved. It depends on the system that is established in the particular county. But on most cases, for example, Karen and we're not typically doing the evaluation, but we do monitor and screen for signs and risk situations for abuse and neglect. And we can do some of the tools that we'll be describing in a few minutes, and we do report. So OT, PT, nursing, medical providers, and many other professionals are deemed to be mandated reporters. Karen, you want to add anything in here about mandated reporting?
Yeah, sure. Yeah, I happened to have pulled up our North Dakota Vulnerable Adult Protection Services document that tells us, you know, as far as North Dakota goes, who is it that is a mandated reporter and when do we report and who should be reporting. So most of your health and human services from your states should have such a document that can be very helpful. I did want to just kind of add one little story about financial exploitation. I had a home care client who was being financially exploited by his daughter, and the daughter didn't really realize that she was financially exploiting him. She came back to town to live with him and just felt that it was okay for her to use his credit card to take trips, buy clothing, all of those types of things. So by the time the elder told me, and I had a very good relationship with him, and this had been going on for 2 years, so the trust factor was there, but he was embarrassed that he was being exploited by his daughter. So being a mandated reporter, I knew I had to report this to somebody, and I said to him, okay, I have to report this. And he said, well, you can go ahead if you want to, but I'm not going to charge her with anything. So, you know, of course, I talked to the supervisor of the agency I was working for, and I talked to our center of, or it's a CVIC is what we call it, which is for violence intervention, and talked with them, told them about the situation. And they said, as far as, you know, since I was in the home and was a kind of a neutral party to kind of keep an eye on what was going on and make sure that no other types of abuse or neglect were going on. But because he wasn't going to charge her, there really wasn't anything that they could do about it. However, we were able to bring in a lawyer to like kind of reduce the amount of money that he owed for the credit card and switch the credit card numbers and things like that. So it, you know, being a mandated reporter, yes, it was important to report it. However, he was not going to follow through with any type of you know, word finding difficulty. He was not going to report it to any of the officials, or so it wasn't going to go anywhere, which makes it difficult.
But you bring up a really good point, because sometimes there's not a lot that people can do about it, because if the person has intact cognition, they are not deemed to be a vulnerable adult, no matter what their condition is. So they have a right to choose how they want to handle the situation of abuse or neglect regardless. So it's like step one of ethical reasoning. Whose issue is it? Well, it's the person who has been harmed. And if they're capable of making decisions on their own independently, then they have a right to handle the situation the way they want. And so they do have that freedom. And it might not always be the direction we recommend, but at least we can do what Karen was saying about giving the supportive resources and helping them access those. So every county has different agencies or social services for the police. Each county has its own process to make a report. And like you said, Minnesota has an elder abuse hotline, so they might actually refer you to that elder abuse reporting center. But the responsible parties named here, the agency or the social services or the police, are the parties who are responsible for conducting a full bore evaluation of the suspected situation of abuse or neglect, if possible. So mandated reporters report the signs and symptoms. They can use other tools and give that to the reporting for the agency they report to, but then the agency takes over the rest of the investigation and evaluation. So we're the messengers, basically. The mandated reporters are the messengers. So most of the interprofessional healthcare providers are deemed to be mandated reporters, and if in doubt, check your state laws. And then if there is an immediate threat, like maybe someone's doing a home health visit and the situation of abuse is escalating, then we have to call 911. It's just that plain and simple. And there may be situations where 911 is warranted as well. There is one tool in occupational therapy called the Occupational Therapy Elder Abuse Checklist. And this would be one tool to evaluate those signs and risk factors for abuse. They have two versions, elders who live alone or elders that live with other people. And so that's something that can go along with the report to the agency. Dr. Steffen?
And there's many different types of evaluation tools that you can use when you just Google, what kind of evaluation tools for abuse and things like that. These are just 3 of them that we put up here for you. The Elder Abuse Suspicion Index, it's a 6-item screening tool, and it can be administered by any healthcare professional. It assesses risk, neglect, emotional and physical, and/or sexual abuse that has occurred in the 12-month period of time. This takes about 2 minutes to complete. The caregiver abuse screen, it's an 8-item tool that asks the caregiver yes or no questions. The older adult financial exploitation measure, it's a quiz that is taken by the older adult to determine if they feel like they're being financially exploited. We did put the links to these 3 assessment tools at the end of this presentation too. So if you're looking for something like that.
So there's, sorry, go ahead.
Nope, go ahead.
There are some indicators of physical abuse, and there are unexplained injuries such as bruises, welts, lacerations, punctures, fractures, burns, pressure ulcers. Any signs of confinement such as rope marks on the wrists or elsewhere. Anybody that is has malnutrition, dehydration, or they're too hot or too cold, any signs of hair pulling, STDs. And then one that's really kind of a hallmark is a pattern of doctor shopping where a caregiver might bring them to different doctors so that the pattern is not seen. So one of these things alone is not necessarily an indicator directly of physical abuse, but if there's a pattern and unclear explanations, then that's something to show a risk. Also delays in seeking medical treatment, and improper use of medication administration, but there again, that's something that needs to be followed up on because maybe they don't understand the instructions.
Can I just add a couple things to that slide too? When we're looking at the bruises, we want to see if they're bilateral, so are there bruises on both of the arms, instead of just one arm? Some of the medications that an elderly person takes can increase bleeding, such as, anticoagulant, maybe Coumadin, warfarin, heparin, whichever, Lovenox, that can cause bruising if the person even just hits their arm against the table or chair or something like that. So we're looking for those bruises that are bilateral, that are, if somebody were to take their hands and put them on their shoulders or put them on their arms and shake them. Some of the sexually transmitted, we talked about the sexually transmitted illnesses. One of the signs for sexual abuse is bruising in the inner thighs. So, and urinary tract infections too, unexplained urinary tract infections also. Okay, when we're looking at the bruising, this is just a kind of a guideline. So, after the injury, 0 to 2 days, we might see some swollen and tender tissue, some swollen on the arms, on the legs, wherever it is that they're hitting or being abused. 0 to 5 days, that area might become red or blue. Within 5 to 7 days, it turns green. 7 to 10 days, yellow. 10 to 14 days, brown. And then within about 2 to 4 weeks, those bruises will start to clear. Of course, this is going to be dependent on the person's age and their medications that they're using too. So this is just kind of just an outline.
So the bruising alone is not necessarily a direct indicator of when possible abuse occurred. However, if the healthcare provider is doing a home health visit and they're talking with their client, and the client says, well, so-and-so came to visit me last week. And then you follow up and you say, oh, how was that visit? And they look down and they're kind of uncomfortable talking about it. And they say, well, it wasn't as much fun as I thought it was going to be. And then you notice, for example, those bilateral bruises, and maybe those bruises are kind of blue and starting to turn green. And then that person said that the visitor was here 5 to 7 days ago, and they're acting funny. That's when you might want to put that in as another piece of the puzzle. And that would be a good time to do the risk assessment tools that we just covered in the prior slides. So it's the combination of multiple signs that are going to make you want to follow up to see if there's something more going on. And then there are indicators for psychological abuse, such as insomnia, sleep deprivation, excessive fears, or ambivalence, like a feeling they don't really want to live anymore, like a giving up kind of feeling. Or there's increased confusion because the psychological distress can affect cognitive functions. Low self-acceptance, any changes in the appetite, anything that's changed, unless it's been going on for a long time, maybe there is something more going on with these changes. Maybe these changes are more chronic and not acute. And illness or paranoia or agitation.
Yep, and then we also want to see, are they maintaining eye contact when you're visiting with them? And when you look at the psychological abuse, some of these are signs and symptoms of depression. So we know, making sure that it's that we're looking for the right thing too. But yes, the psychological abuse, it can be a lot more difficult to identify than physical abuse.
Yeah, one of these things is not an indicator of what's going on. They're indicators that we need to do more assessment. Is it depression? Is it a GI illness that's making them change their appetite? Or is it abuse or neglect? So there are some high-risk situations, and all healthcare providers can screen for these high-risk situations, such as dependence on caregivers who have not had training with the act of caregiving. So anytime an older adult in particular is more dependent with their ADLs and the IADLs, there is a higher risk situation, especially when considering caregiver burnout. Maybe they're working full-time jobs and also providing care on the rest of their time when they're not at work. Anytime there's substance abuse or a psychiatric diagnosis in the caregiver, but now that doesn't mean that a caregiver is going to be abusive or neglectful. It just means that these are higher risk situations according to the literature. And any cycle of family violence that's already in place in the family dynamics.
And Dr. Jansen talked about the caregiving, and being a stressed caregiver is not an excuse for abuse and neglect.
Right. Yes, thank you for making that very clear. And then the abuser, another high-risk situation is if the abuser had a long-standing witnessing of violence, oftentimes across the lifespan. This is another high-risk situation. Or if the caregiver intimidates or abuses for money, shelter, or other incentives in particular. And sometimes it's just a matter of walking in on a phone call and somebody's trying to get money. This happened with somebody who was a nun and was very giving and selfless, and a younger person was trying to get money from her all the time. It just so happened that a nurse walked in to visit the nun, actually, and came in on the phone conversation. And he said, can I talk to him? And he just told this gentleman on the other end of the phone, you need to stop asking her for money because she doesn't have money to give you. And then he reported it. Other high-risk situations is a caregiver who has low self-esteem, who is younger. Again, if they're socially isolated, see how that keeps coming up over and over. And the rates do increase when the spouse is a caregiver. Now, that doesn't mean that any of these people are abusive or neglectful. It means these are just some high-risk situations that we want to pay attention to and compare with all the other signs and symptoms. So there are some AMA screening guidelines. Again, we want to report the incident to Adult Protective Services, such as social services. And if the danger is immediate, we want to create a safety plan. And if the danger is not immediate, we want to be sure to arrange for a private assessment and discuss safety issues, which is hard to do because a lot of times people who have been abused or neglected are very private, like with the case study of Mary. She did not talk about it at all. So it is hard to have those conversations.
Sometimes I've seen in like the clinic situation when the elder who's been abused comes in with the abuser and you wanting to do a assessment, and the abuser will not leave the room. And that's one of the signs that I have seen where you cannot get the abuser out of the room. The person who's being abused will not look at the abuser. So sometimes we have to be creative as to why we need the abuser to leave the room so that you can do an actual physical assessment on them.
Good point. Thank you. And again, that assessment then would include safety, access to resources, cognitive status, emotional status, health and functional status, and all the other additional resources. And then try to figure out why the mistreatment has occurred so that we can develop effective interventions. So now we go back to case study 1, Mary. Mary was the one that had the total hip arthroplasty because her husband had shoved her down the stairway. So if you could please type in the chat box, was that abuse or neglect? Was that abuse or neglect? Thank you, Jonathan. Yes, it was flat out physical abuse. It was. The thing is, Mary did not talk about it. Everybody knew what happened, but they didn't talk about it. So we had to do a home eval for her. So what signs and risk factors are present? Now, in Mary's case, she's in the long-term care facility, and now we're discharge planning. And she says to the therapist, and to the nurse and to the social worker, my husband wants me to come home to the apartment, but my daughter says I can go to her house. So now what are the risk factors? And she's got a new hip replacement. You can type in the chat box. You think she's at risk of getting shoved again? Yeah, she's at risk of more abuse. And if she tells him that she's not coming home to his place, and she says, I'm going to go to my daughter's, what other type of abuse might she endure? How about psychological abuse? So she's at risk of psychological abuse if she has to make the decision to not return to his apartment and instead go to her daughter's house. So where do you think the home eval should be completed? Should it be at her husband's apartment or at her daughter's? Both. Yes, thank you, Nicole. It absolutely should be done at both. And so that is, in fact, what I did. I went to both places. First, I went to the daughter's house. It was a big old square farmhouse. A lot of distance across the floors to get to places. The bedroom and bathroom were upstairs. Well, the bedrooms were upstairs and the bathroom, but there was one bathroom on the main floor as well. And so no, it's not the most accessible for somebody with a hip replacement, a new hip replacement. But you know, they could have a bed downstairs. The couch is a hide-a-bed. She can get in and out of the couch. So, and I did work with her on kitchen mobility with the walker and how to transport items. We can set up a card table at the kitchen so she can sit there and eat. So she can transport her food from the counter to the table pretty easily. And then I went over to her apartment, and that was smaller, but it was shorter distance, easy to reach things. But oh, interesting, there was a launder basket and some other boxes here and there on the floor. So what do you think? What do you think I decided to do? Any guesses? What do you think I wrote in the home eval report? I knew where she wanted to go, but she couldn't tell me that. So somebody had to be the bad guy. And it was interesting because when I was in the apartment, she said to her husband, oh, by the way, you picked up the wrong walker. And he said, oh, dude, what? And he got so angry that I got scared. And I thought, oh, that's it. No, she needs me to make the assertion and draw the conclusion that her daughter's house is more accessible for her with a bedroom or a bed, you know, on the main floor. And that was perfectly manageable for the daughter. So that's what I did. I made the recommendation and I said it was accessibility issues, which it kind of was, but it made it easier for her to be discharged to her daughter's home because she could not have told him that she was going to do that. She needed somebody else to do that. So right or wrong, you know, that's up for discussion. My concern was what she wanted and her safety, and she needed me to do that. So that's how we handled that situation. And then, Dr. Simmons, you want to talk a little bit more about Jerry and the pressure ulcer?
Right. Yep. So this is the lady who was going to be admitted to the long-term care facility. After her hospital stay, she was in her recliner at all times at home. So, are there signs of abuse or neglect that are present, do you feel? And we can put that in the chat. Neglect. Okay, let's see what everybody else says. Neglect, yes. This would be a situation where it was neglect. And we have a maybe lack of knowledge. So yeah, perfect. That leads right into the second question. What high-risk situation might be present? So, and we have lack of knowledge. Let's see what else we have. One of the things that comes to mind when I think about this is, what's the age of the caregiver? Is the caregiver young? Is the caregiver older? Is the caregiver, I mean, we don't have an age on this person. So, yep, the caregiver can be busy with their family. So we have what we call that sandwich generation, where you have, maybe the caregiver is taking care of their younger children, and then they're also taking care of their parents. So they're kind of being squished and they don't have enough time. So, yep, overwhelmed caregiver, some stress. Is the caregiver, is this person an elderly person where their caregiver is their spouse? Is that spouse able to turn them? Is that spouse able to get them up? The situation is that she's in her recliner all day long, and is she incontinent? So there's some situations that we should be looking at to see what is it that she needs. So yes, is there a possibility that the pressure ulcer emerged because of lack of caregiver training? And I think we kind of discussed that in the chat. But yes, when we look at pressure ulcers, is there moisture? Is there friction and shear? Is that causing some of that pressure ulcer? Is it just because you're sitting in this chair and not moving, so pressure is on that pressure point? And what can we do about that? So, and I think we'll talk about that in the next upcoming.
All right, so let's transition to what are some of the interventions. So the role of the interprofessional team is to identify the abuse and then provide aid to the person who's been abused and to the person who may be the abuser in some or many situations, and then be part of the prevention of the situation. So there's strong focus on activities of daily living. If the risk factor is higher for people who are dependent on care for their ADLs and IADLs, then the solution is to help them become more independent. So we do a lot of training with the self-care management skills like transfers and toileting and mobility and even some home management if the person's able to improve on those skills as well. So the more independent the person is, the lower the risk of abuse and neglect. So that's really what we want to do ultimately, is help them be more independent. We can also use wheelchair aids or adaptive equipment to also maximize their independence. So they can have therapists or visits from home services or access to free lending programs like Options. We have a couple agencies in Grand Forks called Options in East Grand Forks, and we also have the North Dakota Association for the Disabled. They have free lending programs for tub benches so they can sit down and swing their legs over and wash themselves, because the transfer is the hardest part of bathing in most cases. We can have them check out for free raised toilet seats and grab bars for the toilet so they can be more independent there. They have free walkers, free tray tables to put on the walker so that they can transport their food while they're making a light meal for themselves. So there's a lot of equipment and training that can be done from the interprofessional team members to maximize their independence. And then, of course, be alert to potential case of abuse and neglect. Identify those risk factors and then provide services, especially home health services, right away to help the caregiver. So the caregivers, we have to pay attention to what the caregivers need. And most caregivers who are not even being neglectful or abusive need three things. They need training, compassion, and respite. I remember one time I was doing a presentation with the North Dakota Caregivers Alliance here in town. So they brought in different caregivers for a meeting, and I found out that one gentleman was in his 80s. He had never heard of a transfer belt. His wife had MS, and he was doing maximal assistance or total assistance in a standing pivot transfer without a belt, no rails, no raised toilet seat, no nothing. And he had never heard of that equipment. So, that's somebody that could absolutely benefit a lot from just simple training on how to use some of that equipment so he's not hurting his back, and it helps her become more independent. And even training, like with pressure ulcer relief. How many people are trained in pressure ulcer relief? How many caregivers know that you have to reposition somebody every 2 hours to prevent a pressure ulcer? So we've got a lot of informal caregivers who are at risk of being neglectful just because they don't have the training. And then we want to give them compassion. If the caregivers are working and providing care, and they're taking care of kids, and they're sandwiched, like you said, Karen, they might just need us to listen and be compassionate, and then just paraphrase, reflect, and ask open-ended questions. How can I help you? It sounds like you're really overwhelmed with all the tasks you need to do. Those words can go a mile with caregivers, and then they build trust in you, and they let you come in and help them and train them. And then the caregivers need respite, and that's one of the most hardest things to do. Respite services. It's very important that we all know what our resources are in the community and see if we can bring in respite. Make those phone calls to the doctors, the home care agencies to see what kind of respite services are available in that county or city. Is there anything you want to add, Karen?
I think it was interesting when you talked about the gait belt, and I think sometimes when we do training, we might rush the training, so not just saying, okay, here's a gait belt, put it on their waist, show me how you put this gait belt on, I'll show you, and then kind of that teach back thing. Now you show me how you would put that on. Yeah. So sometimes it's the method of training that we do too. So, and the respite care is very important, especially if that caregiver is still working and they need to continue maybe to work full-time or part-time, and to get somebody to come in to sit with that elder so that they can continue with their work. Because sometimes what happens is they become resentful. I've had to quit my job, and I know I have to take care for you, and I don't have the finances to care for both you and for myself, and so that that can be quite a stressor that you mentioned in the chat too.
So I did mention the outcome for the intervention was the home evaluation. And I did make the recommendation that Mary be discharged from long-term care to her daughter's home because it's more accessible for her walker, because her husband had boxes and the laundry hamper and whatnot in the way. Yeah, they could have been moved. But from what I saw firsthand, when I saw how angry he got when she told him he picked up the wrong walker, I thought, no, nobody can ask him to move these boxes and the hamper. I mean, it's just an unsafe situation. She really needed the team to help her. She needed that recommendation so that she could go to her daughter's house. And I did know that's what she wanted to, even though it was hard for her to articulate it. So that was the rest of that story. And then she received some more home health services after discharge. So nursing help with the bathing, and she received home care for light housekeeping, OT and PT continued therapies 3 times a week for 2 weeks. We worked on safe kitchen mobility strategies so she could prepare her own meals while using the walker safely and properly. And she used that tray table to transport her items. PT worked on the stairs and shower transfers, so she eventually was able to get up and down the stairs safely. She was pretty stable in her balance. So she learned how to go up with the non-affected or the non-surgical leg and then go down the stairs with the affected leg first. But yes, she improved.
And then going back to Jerry, what are some of the reasons that caregivers may not have received training, support, and respite? And, you can certainly put some comments in the chat if you'd like. So I think some of the reasons is that, if not aware of the situation and not aware of the option, that there is the option to have respite, that there is some support out there, for the person. Poor discharge planning or too quickly discharged. And I certainly can, appreciate that comment, because there's so much that has to be done when you discharge somebody that, do you cover all the bases? Do that training like we talked about. And sometimes we need to consider some of the educational level of the caregiver also. Is this a second language? Medical terminology can be difficult to understand. So, what things could have been done in the home prior to the development of the pressure ulcer? Yes, cushion, absolutely. Certainly, a cushion in the recliner. Sitting in the recliner all day long, putting too much pressure, it is going to, you're going to be at high risk for developing a pressure ulcer. So, and the education, if the person has some moisture problems, and even if they're not incontinent, if you put them on a cushion that is plastic, that's going to create more moisture, so looking at which type of cushion is the best type of cushion. I think that's okay. Any other comments on the intervention for case study 2? Okay.
Karen, can I share just a brief little scenario, a similar situation?
Yeah, absolutely.
There was a gentleman that had a heart attack, went to the hospital, was discharged home. And he had some neurocognitive impairment, like a dementia. And the PT actually referred a home visit to OT. So OT, we scheduled it, went to her home. When I got in the home, the wife came up to me and said, "Oh, I'm so glad you're here. And I'm so nervous. He won't get up. He won't listen to me. He won't let me change his sheets. He won't let me wash him. He's been laying in bed for 2 weeks and he's getting a little sore, but he won't let me change his sheets and clean him up or anything." And she was really quite beside herself. And I went in there and sure enough, he wasn't listening to her. And for whatever reason, he was a very kind man. There was nothing wrong. But he listened to me for some reason. So I was able to get him up. She brought in a plastic chair from the patio. I put that in the tub. I helped him get into the tub, got him showered. I forgot, I scrapped the whole home eval because the need at the moment was excoriation, hygiene, needed to be cleaned up, needed to be dressed, and the wife couldn't do anything with him. And she really couldn't. He wouldn't cooperate with her for whatever reason. And there was no pattern of abuse or anything in that situation. But while he was in the shower, I was on the phone with home health nursing, lining up home health nursing because he wasn't getting any services. She said, "Are you there right now, giving him a shower?" I said, "Yes, I am." And, "Oh, okay." And I said, "Yeah, and his toenails are 2 inches long too." So, "Well, I thought they were cut in the hospital." I said, "No, they weren't." So, I mean, things happen and you just deal with that immediate situation at hand. And sometimes having another person outside is exactly what that person needs. He got cleaned up, got his clothes on, he sat in the lounge chair, and then we got the services lined up. The wife was so grateful because she was just beside herself and didn't know what to do. She said they said that he didn't need home health services. And I said, well, I'm saying he does. So let's get this lined up. And then things were okay thereafter. So sometimes it's just a matter of somebody going in and just helping and doing.
That's interesting that you said that, because one of the things that when I do home care is that sometimes we bring in a younger home care aide, and the person who's at home doesn't want that young person in there, so they'll do better with somebody who's older. So, they said, we need that young person out of here because they don't know what they're doing, and they don't, they're too young to take care of me, so checking to see which type of caregiver would work the best. So, in conclusion, our interprofessional team members can support caregivers through training, support, and offering respite services. So those three things are so important. Recognizing those signs and symptoms if there is abuse going on, neglect. Using some of those checklists that we have provided for you, and they are in the resources at the end of this presentation. Healthcare workers must report signs, but again, they're not responsible for the investigation or drawing conclusions. So there's our references, and then we do have on that very last page those a website for you to go to if you're interested in looking at some of those assessment screening tools.